Welcome back to Sports Medicine on Tap. My name is Brandon O'Lyon. I'm sitting at Neck of the Woods Brewing Company with my good friends Dr. Frey and Dr. Bertha. Gentlemen, how are we doing?
Doing great.
All's well.
Good old Tuesday recording a podcast. Can't complain.
It's been a while. Again.
I know. I think it's the summertime. We got to go a couple weeks and.
I know for me, my daughter graduated from high school. We had family in town, and this and that. Like, it was just a bunch of different things.
Lots of summertime activities.
Summertime.
Life gets very busy in the summertime.
Yeah. we were just actually in down in Maryland, Crab Feast, big lacrosse tournament from my son played, his club team played his Triple H. The high school team lost in the semifinals of the states. Brunson, tough loss. Yeah. They got close. Hopefully getting over the hump next year. But then the club team, their team was Triple H. They played Delco, which is another local area.
Yeah.
And apparently those teams have not played each other in quite a while.
Okay.
A lot of we're from Jersey. One of my son's high school teammates is on his team also from Jersey. So they're sort of out of that mix a little bit. But I guess a lot of those guys know each other, like from school or from the town. A lot of the Triple H guys go to private schools. A lot of the Delco guys go to, and they were going to town on each other, like going nuts, and literally to the point where the ref turns to our coach. He's like, "I've never coached a game where the kids are chirping at each other this much." It was
That's fun.
Yeah, it was great.
It sounds like a good time.
Yeah. Good organization, good weekend. They did pretty well. Yeah, it was nice.
Awesome.
It was nice.
Pretty good goalie too, right?
I like to think so.
Mildly biased, but no.
Mildly biased, yeah, for sure.
Before we go ahead and take a deep dive in tonight's topic, we just want to give a quick shout out to Virtual Orthopedics and Spine. They have you covered from runner's knee to dog walker's hip to yard work back and lab top wrist. They have a doc for that. So find the right specialist for you at virtua.org/ortho. It's kind of exciting tonight because this is our last show in Neck of the Woods until we go to NATA next week in Philadelphia, where we have a big list of guests kind of lined up to record a bunch of different things.
Yeah.
So we're really excited about that. And then one of our renewed sponsored, if you will, Protected, is going to be there at NATA booth 1811. So if you've been listening for a while, you know we love Protected for getting elite athletes back in the game safely. For athletic trainers, it's the ultimate tool belt upgrade. A full suite of customized bracing products ordered via a quick 30-second 3D scan on an iPhone app.
Yeah.
They are the go-to solution for custom face masks used across the NBA, WNBA, elite soccer, and then AC joint pads that don't restrict range of motion, and hand and wrist splints that keep players totally functional. The Protected team is heading into the NATA conference, like I mentioned. Dr. Frey and I will also be there, and we'll stop by at their booth. So if you're attending, and Dr. Bertha will be there as well. So if you're attending, so go check out their 3D printed products in person, like I mentioned, at the NATA booth 1811.
And we've talked about them a bunch of times. Like, showed how they scan. There's apparently some updates on how they do it. And, I don't know, kind of cool. Looking forward to it.
And it's been a little while since we had Kevin on. We had him like an early guest.
That was a while back.
A while ago. He brought some prototypes on the show that night, and it was a lot of cool stuff. And I think we scanned your thumb that night too.
Yeah,
we had
we had
a
a little hand brace. And
A little thumb spike is fun.
Just in case. Just in case. Right.
So a lot of good things coming down the pipeline here. So if you're listening and you're going to be at NATA, check us out on social media. If you're interested in signing up to be a guest on our show, there are a few slots left. So please go to our website and give it a check.
And to be clear, we're back here after that. It's not like this is one of our last shows.
It's just our last show here before NATA.
Right. Yeah.
But we'll be back.
We
love
back.
Neck of the Woods.
We love Neck of the Woods, and we will certainly always be back here. This is for sure our home base.
Speaking of which, they have a brew run.
They do have a little brew run coming, just a little ads for you, right, to get us the shows going. So Saturday, July 11th, they're doing a 5K here at Neck of the Woods. It's through a separate company, so you can go on Neck of the Woods website. They have the sign-up information. You run a 5K. I think it comes with like a beer glass and a beer, so it's a little workout, a little beer. It sounds like a good mix.
I think it's better to go run beer rather than beer run, but do what you want.
You can do the beer mile.
That'll be a fun ordeal. We kind of put tonight's show together on some recent events that were going on. We secretly wanted to do a little World Cup show, but we didn't have the right guest in line to do so. So we kind of pivoted a little bit and brought it back to the home base. And again, we're going to be in Philly recording live next week. So
we'll get our soccer guy back in a couple weeks.
Why not talk about the Philadelphia Phillies and their recent big injury, if you will, that cost Adolis García his season. So it was kind of interesting whole ordeals. Ironically, that we're talking about it, I was watching the game that night when it happened. And when I was looking stuff up again about this, it seems like he made 2 pretty good throws from outfield to home plate, like back-to-back plays. And on the second one, his arm was just kind of hanging afterwards.
Yeah.
And he did not look comfortable at all. And you kind of saw it as soon as he let go of the ball. It's like, uh-oh, that's not good. And then, he got looked at. He waved the medical staff out, and then they took him out of the game. And I think if first reported was like a lat strain, and then a couple days later, it's required surgery, and he's going to be out for 6 to 8 months. He's done for the season. So a lot more news than just a little bit of a lat strain kind of deal. So
Yeah.
what are your guys' thoughts on the whole situation and kind of how we got, the diagnosis and the surgery and all these other things that kind of came out with it?
Yeah, it's a big injury. It's one of those things. It's a lot of force that has to go through that to really tear that. That's not an easy muscle to tear.
No.
It's weird because it's something that you really only see in a very small population of patients that are really doing high level athletics, putting a ton of force through their arm, trying to throw the ball that fast and with that much force. So certainly, the mainstay really be able to truly identify this and diagnose this is more MRI.
Yeah.
Hard, as not, I don't know of any good clinical specific test to say, hey, there's definitely a lat tear. You get some change in kind of the posterior aspect of your shoulder with some of the contour.
I think tendinous in the scapula and within your lat, and but like nothing really definitive.
Yeah, it's almost, I think it's one of those things. It's almost like a pec tear where you can see some of the change, like in the front, but just reversed in the back.
Right.
But like it's hard to really see it clinically, but you can suspect it from these kind of athletes and these kind of injuries and the mechanism and everything like that. With the pain is right.
And there aren't too many, like when we're talking about different topics, there aren't too many times I'm like, oh, I got to go review that because like it's just not something you really see. And so this one came up, I was like, oh my.
This is different.
I got to go check this one out.
Yeah, it's funny. Like when I saw this, I was like, it's again, like, you can't really tear your lat. Like that's not something that's like in your clinical, like your diagnostic toolbox, if you will.
It's not even in like your thought process as you're going through it in general, but like.
Yeah. It's like, I guess it's, Yeah. And again, I think it's something to be said, like, again, we don't know his medical history. Who knows if he was nursing some kind of injury as well.
Right.
If he had some kind of rotator cuff involvement, his lat was doing a little more work than it thought. And then, I think it kind of just goes to like baseball, right? Of like, I forget what inning it was, probably later in the game. So, the up and down of baseball, right? You can go out, you can sit for a little bit and you're an outfielder. Sometimes the ball won't even get hit to you in a whole inning. So you're just out there just ready. Yeah. And then you go back-to-back plays, maximum effort throw to home plate.
Launch it.
You could just been not warmed up enough or whatever the small variables we don't know.
Right.
Could have led to something like this, which is why it makes it pretty interesting.
No, for sure. It's definitely the zebra in the field of horses. It's such an outlier of things. But like I said, in the throwing population in the really high athletics, it is known to happen, even though even there it's rare. So definitely one of those things that there's probably a little part of you in the back of your mind saying, well, it doesn't fit the usual bill.
Right.
This is not really cuff. It's not labrum. It's not the biceps. The usual.
Strange.
Something's different here, and I think that's where it stands out. It's almost like we talked a little bit about like thoracic outlet syndrome a couple episodes ago. It's things like that where it's like this just doesn't fit the bill.
Or like a quadrilateral space syndrome. Like it's like it doesn't quite sort of fit. It doesn't go into the box, and lots of times it doesn't go like neatly into the box, but there's enough overlap with what you're expecting that you're like, it's probably this. And this would be one of those things where like it just doesn't make sense at all. And then you get the MRI and you're like, look at that. Yeah. And then the other really interesting thing about this is that when people do have this injury, lots of times they're non-surgical, and like I guess there's still a big debate because we just don't have a ton of data on it. But I don't even want to say the pendulum is swinging because like the pendulum is just barely exists
really
at
moving,
this point.
Right?
It's
just there.
Yeah.
No, I agree. I think to your point is we don't know the outcomes well enough to say, okay, even if
on
it is
either
a
side.
full thickness tear, like how much does it necessarily matter?
Right.
Because we see so many tears of so many different tendons in the body, and a vast majority of them
do okay.
Yeah, do okay with being torn, and they'll do okay. And it's one of those things. Like, does it really need surgery? Is it really going to be that detrimental, or is it one of those things? If you or I had that torn, does it really matter? Is it really just if you're really trying to get back that very, very high velocity?
I think that's
throwing?
a big part of it. Yeah, for sure. Do you want to go through the mechanism for us a little bit?
So for the most part, from like we mentioned, it was just 2 big throws to home plate, and it seemed like on the eccentric loading of like the stress from when he's throwing and that late cocking early acceleration phase way back here and bringing it all the way over, and that motion itself. And I think typically throwing mechanics, if you will, they're generally focused on a pitcher from a stationary point, set. For outfielder, right, he's fielding the ball, then he's crow hopping, and he's all very much more of dynamic movement.
Right.
So little things to change in that regard. And like we mentioned, if something was going on with that too, of like if he had pre-existing soreness or whatever the case is, it's also going through that. But cocking all the way back and then violently going forward, just that change in force in the lat just could be just overload, right? Just classic muscular injury, dynamic overload of some sort, which is what he was trying to do, trying to beat a runner to the plate. The throw was pretty close, even with an injury, which is usually when an injured throw, the ball goes sails somewhere or whatever. So at least he was kind of on target, even with that damage there. But I just think it was like one of those things where just the right recipe for disaster kind of happened for him at that time with the big throw. And I think, I don't know, if he only made 1 throw in that inning to home plate, not back-to-back plays, would have made it any different.
Right.
I don't know. And it's something...
If it happened 3 innings later, would it have been a problem, or would it have been okay because he had a little bit of time?
Yeah. Hard to say. I mean, I think it's like some of these tendon injuries, though, I think are interesting because, I'll kind of refer to like distal biceps tendons.
Yeah.
If you look at like an intact bicep tendon, it's not that big.
Yeah.
But everyone that tears it, you get in there and it's huge. It's this big bulbous structure. And it's one of those things, it's the age-old question was it already changed before you got there? And was this kind of about to actually happen no matter what?
Right.
Or was it truly, it was like, hey, just totally out of the blue. All of a sudden this just tore. Or has it actually been kind of a chronic thing that just wasn't showing its face and finally gave?
Tear here, little tear here, heal, little tear, heal, and becomes more tendinotic and inflamed and thickened. And on the verge of like giving way. Yeah.
And I think it's also pretty interesting because if you look at Adolis García, he's a very large mammal. He's a big jacked guy. You know what I mean? So he puts a lot of force in it, and he's a very strong person. You would think that the lat is such a strong muscle, such a strong posterior muscle, especially in the world of baseball. Like it's a muscle that's trained regularly all the time, that someone that big, that strong would have something like this happen to him.
Yeah. And so, and I think you just made a great point, right? Like when we think of lat, we think this big kind of triangular muscle that comes from your back, and everyone has this big, huge one on them. But where they tear is like at the either musculotendinous junction where it attaches to the arm, to the humerus, or literally where the tendon attaches to the humerus. And it's actually shockingly fairly far forward in the humerus. And so in the world of orthopedics, or actually the world of medicine, to be honest with you, right? Like we have these mnemonics, different things we come up with when we're learning stuff, and to help you remember some very complicated things, and oftentimes they're a little bit raunchy, and it helps you think. And the classic one that I think that a lot of med students know and remember was the cranial nerves, right? Like, do you remember the mnemonic or no?
I know what you're talking about. Yes. I can't think of the whole thing, but I know what you're talking about.
So, to touch and feel Vera's great vagina, heaven. Like, and that was like the first letter for each one of the 12 cranial nerves.
Right.
And then, so like, there's all these different mnemonics, and the mnemonic that I learned when I was a resident to remember the insertions it's the lady between 2 majors, the lat dorsi, like LADI, the lady between pec major, which is on the lateral lip of the intertubercular groove, then the lat dorsi, and then the teres major. So it inserts right between the 2 majors, the lady, and which is again your raunchy kind of funny thing to remember.
Right.
But if you think about where pec major inserts, that's like here, right? Like that's near the front. Then you have biceps groove with the biceps tendon, and then literally right next to that is lat dorsi, teres major. So like it surprisingly goes like wraps all the way up and under and pretty far towards the front when it tears. And then the other factor with all of that is that when you have an injury to the lat dorsi, and I think this actually probably contributes to whether or not someone needs surgery. Lots of times that there are attachments that go to teres major, so you get a tear of them both. Now, teres major is not technically rotator cuff. Teres minor is, but teres major isn't. Yeah, I have to imagine that he probably impacted both. It was probably lat dorsi, and it's the tendon where it attaches up near the arm, not down in your back, that you have the injury, and then he probably also tore part of the teres major.
No, I would agree. Those two, as they really insert, are very intimately related to each other. And like you said, it's such a weird spot to me because I think for years it's like really that gets there. Like how does that get through to that region? You know, but it does, and it's one of those things. Even when you do an approach to a total shoulder, you actually get down, and as you go through, you can actually see the upper border of that, and you can even reroute it from the front. So there's things that you can do with it. It's fine. It's findable, so to speak, but it's not where you would expect it to be, and it does a little bit different function than I think you really kind of give it credit for.
Than you're thinking about.
You think it'd be kind of a little bit more posterior, kind of where it starts at, but it is a super powerful muscle, and it's one of those things I think. When you get in there, the tendon, it's almost kind of more like the pec as well.
Right.
It's different than some of the other ones where it's this more broad insertion. And it's not this kind of small tube that goes onto it.
It's thick.
And it's it's one of these things that it's a little different than some of the other things that you see. But it does, it repairs down well. You can use it. We use it for transfers to other tendons as well.
So I was going to say, like that's. I don't think that's something that's readily thought about. But if someone has an irreparable rotator cuff tear, something that you can't fix anymore, and especially like a younger patient, you don't have a ton of options. One of the options is transfer lat dorsi tendon up and over and fill the hole with that. So it is. What?
Yeah, no, it works good. It's one of those things. It's a nice alternative for those irreparable tears.
Yeah,
and I think it's pretty interesting, and I'll ask your opinions on this too. Is like the call to go to surgery. Like I felt like it was not fat. I mean, it's major or professional sports. Like usually those surgical calls are made pretty quickly. But I've seen maybe like 2 injuries to the lat of like that were like noticeable on clinical exam of like more or less like it was super bruised and like swollen, where like the one was a baseball pitcher and one was a quarterback, typical throwing athlete like you would expect. One was it was like a ball, like a black and blue ball was in his armpit kind of deal, and it was just really swollen. It was just from not throwing for a while. It was a quarterback, he didn't throw for a while, and he started picking it back up, and classic, you ramp up activity without doing too much, the muscle gives out. And the other one was a baseball pitcher kind of over time was dealing with a couple different things. And then he just started to have this swelling in his armpit. And it was like, we thought it was other systemic things of like swollen lymph nodes in your armpit.
That's the first thing you worry about.
Not like a lat injury. And I think at the time, the team doctors I was working with did like a diagnostic ultrasound in clinic, in office, and just saw like the muscle fibers were torn, and it wasn't anything other than just that. And it was just based on exam, it was just like kind of like a mild lat tear. Treated non-conservatively, just rehabbed it, and everything was fine.
Conservatively or non-conservatively?
No, conservatively.
Okay.
So non-surgical. And with some rehab and some time off, the pitcher came back that year and pitched well. The quarterback, same idea. He went back to practicing and throwing, no problems in a few weeks.
Right.
So when I saw it, I was like, wow, they went not right to surgery, but they go to surgery.
Well, I think that's the hard thing. What we were saying is like I don't think we have enough data to really say one way or the other whether it matters. And I think to the point we were just making is that we use that muscle to reroute for people that have irreparable cuff tears.
Right.
And they get better function moving forward because they didn't have that before. So it's one of these things like, how important is it really? Because we can use it and kind of substitute out, because your body, especially in this area, has so much redundancy of what muscles are doing these same activities. We talked about teres major, we talked about pec, like all these things are playing into similar roles is what lat does, and does similar concepts. So it's one of those things, I'm not saying that it's, if it tears that it's not worthwhile, but maybe just in that really select population, is it worthwhile? To me, the question is, if we did nothing for that and we just waited and rehabbed it out, would he get back and be the same?
Would he be okay?
Hard to say. I don't think anyone will ever try it.
Right. Right. Yeah, we'll never know. And upon hearing that, so like I think standardly for the most part, surgical intervention was reserved for people who failed non-operative management. Usually you would try non-op first. Some of the indications I think that could be for surgery, if there's greater than 2 centimeters of retraction, full thickness tear, especially if it's directly off a bone as opposed to at the musculotendinous junction, where they tend to heal a little bit better. And then, it was there, teres major involvement. We don't have, we've done the disclaimer a million times. We don't know we don't have access to his medical chart. We don't know the specifics on his injury. All we have is the general information they released to the public. But presumably, based on the fact that they went right to surgery just the way that they did, I'm guessing it was full
Pretty
thickness tear,
yeah.
probably 3-4 centimeters retracted, and probably teres majors probably off as well. And they said this guy, like as a professional baseball player, he may struggle getting back to that same level unless we repair this. Let's just do it right away.
Yeah, and I think from a team, like a professional sports standpoint and kind of a legality standpoint, it's one of those things. If you decide to do nothing, and he doesn't get back, then it's going to be one of these things. Like,
should have done it.
Should we have done it? Yeah. It's the age old question, and then you go down because it's like, well, you knew it was torn, you didn't do anything,
right?
So it's hard.
Yeah.
Honestly, my gut instinct tells me that it probably doesn't make that much of a difference,
right?
And it probably would do okay. But like I said, I don't think anyone would ever try it with high professional athletes and really kind of see where it goes.
I've seen one in my career, non-opt, and he did fine. It's just not very common, you know. Yeah.
And I think also, to play the game of pro sports here a little bit, he's 33 years old. He's kind of a little older.
Right.
So maybe trying to save this fourth quarter of his career kind of deal, trying to get some more out of it. And, if I'm not mistaken, he's only on a 1-year deal with the Phillies. So
that's true.
That's also just, again, where medicine and business kind of clash with where they're like, well, if we take care of him, hopefully he re-signs with us. And if he's still valuable, it's still, I would imagine it's a cheap investment to keep going forward to if you can fix him, get him back, rehab him, and keep him in your system.
Get him for less.
Re-sign him for something less, right? Maybe. He's got a little damaged goods.
Yeah. Right.
Might be a good move.
And granted, he was starting to
find his rhythm.
Starting to find his rhythm, but up until that point, he wasn't lighting it up.
No, it wasn't the greatest idea.
He's still a great defensive player.
Right. Yeah. And he had a cannon of an arm till it kind of came out. So I think it's one of those things where we kind of watch and see.
Yeah.
I think from what I was reading, for the most part, and again, this is something that one of those things where I don't even know what the return to play timeline for that is.
Yeah.
For everywhere I was reading online, it's 6 to 8 months, pretty strict protocol, which makes sense, especially for a return to throw for that as well.
I don't think he's throwing a ball for a bare minimum of 4.5, 5 months, bare minimum to even light toss.
Yeah, totally agree.
Yeah,
totally agree.
So it's got to be 6 months plus until he's able to come back.
It's one of those things. To get that to start to heal in, you're going to be limiting him. Almost the opposite of some of what we do in some of these procedures where, we have them in more of an abduction sling here to kind of tension things off. And here, we really want them to be kind of close down. So it takes the tension off the repair.
Probably internally rotate too to bring that.
You're going to be sitting there like this for 6 weeks. And that's, you're going to get stiff. You're going to need to stretch all that back out. I'm sure he's going to get capsular tightness in his shoulder, trying to get back and be able to get the range that he normally has to throw with the velocity that he can. I think it's going to be a long process. And I agree with you. I think at best, I would say, we're starting to just do light tossing at best 4.5, 5 months kind of time frame. So.
And this is not that. So then now this is getting probably a little bit above what people really care or interested in. We might lose the average listener, but it's posterior approach to the shoulder. So it's so different than what we're used to. We do a lot of arthroscopic surgery, and then if we do some open surgery, do some open surgery from the front. And this is an odd one. Right? Incision in the back of the shoulder, digging through the almost axilla to the front.
No, it's a weird procedure. You know, it's one of those things. It gets into these more ancillary type procedures. I've done procedures in the past, doing ones where you transfer pec down to scapula and things like that, and it gets odd because you're by the chest wall, and you're seeing anatomy that you don't usually do.
Right. I'm ortho. I'm not supposed to be over here.
Yeah, it's this is not what I want to see here.
Right.
Yeah.
So it becomes a little bit more of a scrunch for you.
Right. Right. Yeah. Person up a little bit.
So I guess for the next part would be your estimate or guess, if you will, of how he returns, and if he returns to a similar level, or is he going to be lesser, and this is kind of the tail end for him?
Done for the year.
For sure, yeah.
Comes back next year. Where are we now? We're in June.
Yeah.
Yeah. I getting ready, should be ready to go for spring training, like, ramping up with spring training or something along those lines. And let's say gets back to nearly close to 100%. If he can find his hitting again, he still has a career left. If he can't, then this might be the beginning of the end. Yeah.
No, I agree. I agree entirely. I think he'll be back. I think once he makes the recovery, I think he'll be okay.
Yeah.
I don't think it's going to be one of these things. I mean, barring any unforeseen circumstances, I think it's one of those things he'll get back and be like, okay, I feel all right. Like I can do what I pretty much did before.
Yeah.
Yeah. So something we'll keep an eye on, and hopefully by next spring training he will be back, and hopefully a Phillies uniform if they can, they rehab him really well and get him back to
make
going,
it
happen and fix all the things that he needs, And I think
in the meantime, there's a hole.
Yeah. In the meantime, we got to figure out what we're doing there for sure. But something you mentioned, Dr. Bertha, was like, with this surgery, he's going to be stuck in this sling. He's going to come out real tight and real stiff. And I'm going to use that as a bit of a segue going into our next topic here. Something I was texting with Dr. Frey, I think, briefly about was the case of Malik Nabers. We're going to shift gears a little bit, go from baseball to football. But recently it was reported that he underwent a second procedure on his previously repaired ACL knee. And I was like, ooh, that's a big red flag in my book for, just for his outlook of, all that stuff.
Can be worrisome.
Could be a bit worrisome. And I think, and then not too long after that procedure, he was seen at a charity softball event, kind of gimping around a little bit. It wasn't really moving too great, but he was still there to show support for whoever was running it or whatever the case was. So I wanted to take a deep dive into this topic and kind of give our listeners a bit of our take on this, what the second procedure for Malik Nabers kind of means.
Yeah.
Yeah, so I think there's the most common thing that we see for this really afterwards, typically around 6 months after the surgery, so people can start forming some scar tissue in the front of their knee right by the ACL that we've reconstructed.
Yeah.
And you can build up what we call a cyclops lesion. And essentially it's a ball of tissue.
Ball of scar tissue.
That just sits kind of right there in the front. And as you can imagine in your knee, that ball of tissue in the front, as you kind of come into full extension, it impinges and it prevents you from getting out to full extension. So that's kind of the scenario that we usually see. People tend to limp around and gimp, and it's one of those things. It's
painful
all of a
click.
sudden, yeah, exactly. And you go from having full extension and feeling pretty good to being like, I'm losing my motion.
Yeah.
So it's not an uncommon thing to see.
Right.
The good thing is that it's a pretty easy fix.
Yeah.
You just kind of go in, you can shave out that tissue. It's like the recovery like you do when you do a meniscectomy, whereas you're just really kind of waiting for things to heal up from the incision standpoint, get the inflammation down, and start moving forward with your rehab.
I feel like people do even better, to be honest with you.
Yeah.
Like they do better relatively quickly. Yeah.
Mm-hmm.
Like they kind of bounce right back. And sometimes I think that some of these people have been struggling a little bit with that extension sort of the whole way through,
right.
Up until that point, and it all of a sudden started getting even worse at that point.
Mm-hmm.
And then they get this painful click, and like, what is going on here?
Yeah.
You do the MRI, and there's a big ball of scar tissue right in the front of the knee, that very typical spot. And I find like after you do it, like lots of times, like they're like, man, my motion, this is the best it's been since I had the surgery.
awesome.
Like, it's great.
Yeah.
And they get bounced back pretty quickly and get going pretty quickly. So, you hear that second surgery, and the first thing you think is like, oh no.
Yeah.
But I think in reality, this is that minor one. This is not the oh no version of it. People typically do fine. The big thing is like, is the graft okay? If the
Right.
ACL graft is okay, and was there an associated meniscal injury that initially that either got missed or got repaired and then retore or something along those lines.
Yeah.
Those are much more worrisome things and
For sure.
take a little bit longer. But when it turns out cyclops lesion, scar tissue, they do really well with this.
And it's a quick procedure. I mean, you're in there, you see. I mean, I think it's interesting just for anyone listening that we call it a cyclops lesion because if you get in there, it literally is it's just a ball. It looks like just a big eye of a cyclops.
It's like a marble. Yeah.
And you see this big piece there, and it comes out easily and does a great job. Now, I think what's interesting, and it's a bit of a controversial topic of cyclops lesions, is why do they form or where do they come from?
That's a great question. Yeah. I was debating, should we go down this road or not?
I don't want to get too in depth, but I do want to hear your thoughts on it. I mean, I think that there's some element. When we put that graft in, if you have a little bit of too much tissue that's going through, or things that are frayed at those edges, I do think that those can be an attractant for causing more scarring.
Yeah.
So when I put in the ACL, if there's pieces that I feel like are free, I will touch up the graft and I will try to kind of just debride a little bit of that.
Make it look nicer.
And I like to think in my head that it helps.
Right.
But it's a hard thing to prove.
Yeah, for sure. No. Do you do a little monocryl, like a little stitch around the graft to tuck it all in and keep it nice and tight and make it look better just on the pictures, or do you not do it?
So not routinely. Only if I feel like there's a real piece that is kind of flayed out and that's really kind of starting to get out of the way.
Back in there.
And then exactly. I'll use it to try to kind of hold it in there.
Yeah.
But as long as it looks pretty ubiquitous and pretty straight, I'll kind of keep it as is and go from there.
That could very well be the case. That could be the underlying issue. I know I actually spend a little more time than I think the average person cleaning up the stump of the old ACL that was there, kind of clearing that all away, hoping that in case that's a contributing factor. This is not science. This is anecdotal, but I do an internal brace essentially with every ACL that I do. I'll put in an extra thick stitch. It's like a suture, but kind of a thicker suture. We've talked about an internal brace, 1,000 times in the show.
Right.
And I like putting that in as sort of just extra, support for the graft until the graft incorporates and goes on. I think that I've noticed an increase, not dramatic, but a little bit of an increase in people getting cyclops lesions since I added the internal brace. And I wonder if having that extra material in there is a factor. I do. I wonder. I don't know, but it's just one of the thoughts that I had.
I mean, it's a great question. I mean, like I said, I think in general, I think it stems largely from additional tissue that's in the area that's not well compact. So I can see if that's the case that it starts kind of forming that. But I do also agree with you that remnant area on the stump of the ACL, I think cleaning that up, is beneficial because I think it's the same concept. The more tissue that's there, I think the more problems you're going to have.
Right. And then I also at times wonder, could it be like sometimes we'll do a notchplasty, sometimes we don't do a notchplasty. If that was a really tight notch and whatnot, and does that then also so notchplasty is if you have to make a little more room in the garage for the car. If the notch, a little thing in the area in the center, then you were putting the ACL. If someone happens to have a particularly tight notch, then you worry, is it going to abrade your graft? And sometimes you just shave a little bit of the bone out, make a little more room in the garage. And so that jump starts a healing response. And does that then, because that's the same area where you get the cyclops. Could that, I don't know. I really don't know. I wonder.
It's a lot of different factors that play into it. And I certainly think too that there's a patient specific component of that as well.
Yeah.
I mean, there
scar
are
formers.
Exactly. There are some people, they just scar. And I think it's 100%. One of those things, there's almost nothing that you can do about it for better or for worse. They just form scar, and when they do, it is thick.
Yeah, and I also wonder if there's some kind of component with the scar buildup and just kind of their compliance to their rehab early on to early motion and other things like that.
Right.
I haven't seen enough of my ACL athletes come back. They've had this and had to go to get second surgeries. I've had a few. But not much of where I could make a good hypothesis of
why?
It's because of this. I don't have that.
Yeah.
But my brain just tells me is there something are they someone who scars a lot, or is there someone who's they're just so afraid to move it because they have a little bit of pain? We're no, that motion is gonna hurt, unfortunately, in the beginning stages of rehab, right? It's not going to feel good. I remember specifically grabbing onto the table when I was getting my knee worked on after my ACL surgery. And it was one of the worst things ever.
Right.
And I tell my patients now, I'm look, I know exactly what this is going to feel like, and I'm going to warn you, it's not going to be good. Find your happy place and let's work through this so you don't have to deal with something like this.
It's not going to be good.
Yeah. I do agree with you. I mean, there are certainly people that are scar formers, but I do think, especially from an arthrofiber, a stiffening of the knee standpoint, I think it's a big mental game.
Yeah.
It hurts.
It does.
And I think it's a tough hurdle for people that it hurts, so they think, I can't do this, I'm doing something wrong.
Right.
But in reality, if it's time to go and you're not going, it's only going to be worse later. Like it's just going to yeah.
For sure.
Exactly.
I harp on people in the office. I tell them all the time, like getting out to that full extension, about how important that is, because you don't want to be stuck in this position where you've lost that last bit.
It's tough.
And it doesn't take much.
No.
You know, just a couple degrees totally throws off your ability to walk and move around the way you normally.
Yeah.
So it's a big deal.
Yeah, like the one person I've had that had to go in for a second procedure was a very interesting scenario where they weren't from here. They're an international student from a Caribbean island, and their family, their belief was very much anti-surgery.
Yeah.
But this patient tore their ACL playing soccer. So well, like if you ever want to play soccer again, like this is the only way to really make this happen. Like I don't think you're going to be a coper. So it was just like I think there was like an external negative environment that this patient was in where like they didn't want to do the rehab. They didn't know. They didn't want to like burden anybody with doing extra stuff. And then, sure enough, and their lack of compliance led them to these issues down the road.
Yeah, for sure.
I mean, as we all know, the PT portion of this is just as important as the actual surgery, if not more important.
Right.
You know, like
well said.
It is super critical for the success of the surgery. I mean, I've heard many surgeons at times say, you know, I just kind of essentially, you know, I've done my half. Now you got to do your half and really start moving this.
Right.
You know? So it's super important. You know, we can only do so much of kind of getting the ports in the right spot. You know, then we got to get it moving and straight.
Yeah, and I think it's definitely an underappreciated thing of like how these little things early on will help down the line. Like you mentioned, like a little 2 degrees difference from your anatomical normal can change your total gait, and then years down the line you're dealing with ankle and hip issues or whatever the case is.
I don't fully wholeheartedly agree with that statement. I think you can function with up to 10 degrees loss and function pretty well, but you can see it, right? You can see the difference, and it bothers people, and understandably so. Once you start getting more than that, then you got a real issue. But like that 5 degree, like you can see, you can still do fine functionally, but like it's less than ideal. In a perfect world, you really want to get it fully back.
For sure.
So again, we'll kind of end with the Malik Nabers topic. Is what do you guys think of his return for this upcoming season and his productivity level?
When was the original injury?
So the original,
or was it early?
October. So his original surgery was October 28th of 2025, and then he went and just had his second surgery in April of 2026. So
I think that it's a speed bump. I think that his recovery will be about the same timeline-wise, as if he didn't have it. Mm-hmm. I think that if you get to it at, you know, kind of at that 6 month mark, which is where it sounds like he
pretty much
a little bit after,
yeah.
So then all of a sudden now, you know, assuming the timeline was going to be 9 months, assuming, right, like we don't know, it's always around 9 months, could be a little bit long. Assuming it was going to be about 9 months, I think his timeline will now be like 9.5 months. Like, you know, like it's going to be pretty close to where it would have been if they kind of dragged their feet and didn't do the repeat imaging and whatnot, and then he's getting that repeat procedure at the 9 month mark. But then he's looking at 10.5 months, that kind of a thing. But because they got it when they got it, I think it's almost the same timeline.
Yeah, I agreed. I like we talked about. I think it's a short recovery from that. It's quick in, quick out, and you're feeling pretty good.
Back on track after that.
Yeah. So, in fact, I think it's one of those things. Kind of like Steve alluded to, it's you almost feel better right after. Like it's kind of like, oh man, I was going and I couldn't make this full extension. Now I can, and like I can do
that
what
roadblock is gone, so they can move a little bit, right? Yeah. And I think also for him in general, like I think a bit from a fantasy football perspective, a statistical standpoint, he's going to have a lower down year. It's not going to be his greatest.
Probably.
But I think overall he's going to be better off because now he also has some other chronic things that he's been dealing with for a while. He has a chronic turf toe, this toe injury that he's had for all through college, and this. He may have had his golden window now of a good 8 months to recover and hopefully fix that as well.
That's a good point.
And then now you're getting everything, all the new tires on the car, if you will. Everything should be full steam ahead once he gets I don't know, I kind of say that first year back from ACL, whatever you get is a win.
Yeah.
That second year is when you can expect elite level of production at that point.
Right.
So I think
it's a great point about giving the other injuries time to heal too.
Yeah. So if they fix the toe and the knee's working pretty good, I think he could be, pretty good asset for the Giants going down the stretch. But see what happens.
A lot of potential on that team, right?
Yeah.
Right. And then you had Scatterboo, right, at that same softball game doing a backflip.
Yeah. I mean, that guy.
It's unbelievable.
He's a special breed.
Easy, special person.
breed.
Yeah. Holy cow.
Yes. They do have a lot of talent. We'll see how they do.
A lot of young talent, and they also have
What's
Odell
that?
Beckham back.
Fan, right?
No, Steelers.
No, Steelers.
Yeah.
It's a baseball. I forget. You like some New York teams, don't you?
Yeah, I do. Pretty much the rest New York
Right,
teams,
I got
but for whatever reason, Steelers. Yeah.
My bad.
And you do like the Knicks, right?
I do like the Knicks.
How about the
my.
champion Knicks, huh?
Look at that.
Yeah. Yeah.
So-
And for a while, as an organization, I didn't love the Knicks. I grew up a huge fan, and then kind of got turned off a little bit by, I think, a few down years. I don't think, again, I didn't love the organization. And then all it took was them doing pretty well again. I was right back in. It's hard not to be drawn back. And
Right.
Yeah, and they're a really likable team. You know,
Yeah.
they are. I still don't understand how, like I keep saying this, right? NBA teams are made up of college all-stars, right? It's a college all-star team, right?
Yeah.
And that's an average NBA team.
Yep.
How do you take 3 guys from one team, put them on an NBA team, and granted they had 2 other guys, the main guys, and go and win an NBA title with that? How?
It's crazy.
Not
It's
even that, but just
unbelievable.
another championship together.
Right, another
I think
championship
winning
together.
the NCAA championship is arguably just as hard as winning an NBA championship.
Right, right.
And it's how do these guys do it on another level 10 years later?
Right.
And it's not okay, I think the story would be different if for whatever reason, they're Villanova 2016.
Yeah.
2017, somehow they all get drafted to the same team. They win that following year.
Yeah.
Unbelievable athletes, crazy. But this is 10 years in the
10
making.
years, yeah.
They've been all over. They all went to different teams, and they
Yeah.
all kind of regrouped, and then they figured it out.
Yeah. It shows how important, knowing the guys you play with.
Chemistry is
how
for
big
sure.
chemistry is.
Yeah, exactly. I was going to say, it's all about the chemistry of knowing who you're playing with, know how you can build off each other and be able to make that work. So I think that's the key for them is they know how they can make each other work. I mean, it's the thing is you always think about, and I don't know, I don't know if I have specific examples, but you have those certain players where they're a little bit more of a ball hog.
Yeah.
And if you put 5 of those guys on a team,
No matter how good they are.
doesn't matter. They're not going to do well.
Yeah.
They're going to fold because they can't work unified together.
Yeah.
And I think that's where they excel is that they work together as a group.
Or they're going to do really good and then not do well for a long period of time, like a Shaq and Kobe scenario, right? Both guys who were dominant but they both wanted the ball in their hands when it mattered.
Right.
And then eventually they split. They had their success,
Yeah.
but then they split and they had their success without
Separately.
each other as well.
Yeah.
But I think it's one of those examples of kind of what you're alluding to.
And they didn't just win.
They dominated. It was a dominant
It was
run.
an unbelievable run.
You're
It was crazy. It was fun to watch that.
Yeah.
And I mean, I think it kind of got a little nerve-wracking in, what was that, game 1 when Jalen Brunson went down with a little knee buckle. And I think the whole...
I think it's over.
You could hear a pin drop in the whole city of New York after that happened.
He's
It was
grabbing his knee.
grabbing,
Yeah.
You don't want it, I don't know. I guess that kind of gives me the vibe of that incident reminded me of whenever the year Derrick Rose went down with it.
Yeah.
Great year for the Bulls.
Yeah.
Goes in the playoffs and first round tears his ACL and
Yeah.
kind of alters his whole career at that point.
Yeah. He was never the same.
Never the same. And then so you see that happen.
Mentally also, he was different.
Right.
Yeah.
But you get those, I didn't really watch much of the finals, but you get the notification, Jalen Brunson down with a knee injury.
Right.
That's it. The Knicks are done. They're done,
I still wonder what was it just hyperextension, a tweak, or MCL or something? He played through it, or was there meniscal and is there going to be off-season surgery that we don't know about? Something,
Right.
yeah. Because when it happened, it did not look promising.
No.
Yeah.
No, I was gonna say it's those more hyperextension type injuries. They look bad.
Right.
They always look nasty, and you
Yeah.
always worry that something's going to be really detrimental. But it's one of those things. If it's a small, I guess what I'll call a smaller injury, or something that's not going to be kind of totally stopping you to be able to get back. You can get back, and you might not be playing 100%, but you could do solid. You could do well. With the right treatments.
And that guy's clutch. I mean,
Oh, man.
It's unbelievable what he can do down the stretch.
Yeah.
An OG Anunoby keeping it, like the one time that Jalen came up short with his 3-pointer, then there's OG tapping it in.
And he was not injury-free either in the playoff run.
No.
He was dealing on and off with hamstring issues, which is
oh,
you never, there's obviously no injuries you want to deal with in a championships in playoffs or whatever, but you get a hamstring and you're like, oh man,
hamstrings and calves.
Hamstring, like you don't want the soft tissue stuff to come up late in it because then you're going to try to push it when it's probably a little too early, and then you roll the dice like we mentioned earlier, like you push it, play a little, and then something happens and you do more damage than you could if you waited or whatever the case is, but. In the scenario of championship sports medicine, if you will, you push the envelope a little bit.
Of course. It's that posterior leg. It just kills people. Hamstrings, calves. They just keep nagging on and on and on.
Yeah, and you never want to see it. And then, another team that beat down on Philly in the playoffs was the Carolina Hurricanes, who ended up winning the whole thing as well.
They were good. I predicted early. You said. I think you said that it's going to be Carolina or Vegas, and then sure enough, that's who.
They did good. Yeah. I was going to say they were impressive.
Yeah.
But I think it's funny how the NHL works, and we've mentioned this before. They're very much closed doors when it comes to their injury reporting. It's upper body, lower body injury.
Yeah.
But then, it's kind of interesting after the finals. It's like, oh, look at all these people having surgery now. Like, all these things are all jacked up and, messed up. Mark Stone was playing through a torn adductor muscle, which I don't, reading that is that's got to really hurt, let alone ice skating on a torn adductor. I would imagine there's a lot of adductor involvement in the world of skating and changing directions on ice.
Yeah, that's a classic hockey player injury, actually, the adductor. And then then that leads into, is this a sports hernia or is it? Yeah.
And I think, to Steve's point, with the hockey players and the fact that they had these skates over their ankles, where a lot of players will get more of these ankle sprains and things like basketball or something like that, they're protected from there.
Right.
But everything more proximal takes on that force because of that. You get a lot of MCL sprains, adductor, all those kind of things like that end up seeing more of this.
And I think the grit, if you will, to win a Stanley Cup playoffs is just one of the biggest things in sports. Playing those games of hockey is so brutal, so physically demanding. And then I think it was pretty awesome that it came out afterwards that their coach was having the guys. You guys see the story about them lifting the cinder block in their weight room?
No.
So a couple years when Brenda Moore went down to Carolina, he worked with the strength conditioning staff, and he wanted them to do something that was just kind of like a blue collar press is what they ended up calling it. And they had a cinder block, which is about 35 pounds. And before they left the weight room, they had to pick it up and put it up overhead. And then afterwards, I think it was a game before they ended up winning it. Their coach finally told him, he goes, hey, you guys want to know why we have that cinder block in the weight room? He goes, it's 35 pounds. You know how much a Stanley Cup weighs? 35 pounds.
No, I didn't.
And so every time the guys they ended it with they called it a blue collar press. They took it and lifted it up over the head. Yeah. And sure enough, all those guys were lifting the trophy up, celebrating.
Awesome.
And he was setting that mindset of the championship mindset of lifting the cup up way before anybody knew about it. And I think I saw a report when he told a reporter, he told him, I don't know, sometime during the finals, one of the last games, he kind of told him why they did it. And I think it was probably one of the best pregame speeches ever.
I'm sure.
He set it up for years. I was going to say, that's an awesome
It was
setup.
marinating for years before he let that one go. And it was...
you guys are ready for this. You've been training, literally, to lift that cup.
And that goes back to...
that's awesome. That's got to be such a good feeling. This is sweet.
That's similar to Jimmy V when he was down in NC State and they practiced cutting the nets off after practices before they won the championship.
I didn't know that Jimmy V did that, but that sounds right.
I believe that's a story of where they would practice after practice. All right, guys, let's do it. They get the ladders out, they cut the nets off, and they practice winning. And I think that mindset, that visualization mindset is a bit of a sports psychology side note of it just breeds that championship mentality in which you need in these long stretches of these 7-game series of all these brutal sports. And hey, it paid off.
Yeah.
It's funny. I had some friends that were involved in a lot of high level athletics and they would always say it's all mental, and I do agree with that. I think that there's a huge component of this is if you have the right mindset and you know what it is that you want to do, you can push yourself that next level and be able to achieve that. I mean, obviously, there's a huge physical component, but that endurance and that resilience comes down, especially in the Stanley Cup playoffs or NBA and NHL where you have these 7-game series. Those things really come into key where it's such a long road to get there.
And I think it's just crazy how these guys end up showing up on the ice and performing at a high level with so many things that are the average person wouldn't get out of their bed if they had any of these injuries on a normal day. And these guys are out playing hockey, basketball, whatever the case is, and performing at the highest level.
Yeah.
And half of them won, half of them lost, whatever. But it's still very impressive of what the human mind can do and what the human body can do under all these circumstances. And I think that's part of the draw of what for me, doing it, living on my career on the sideline, seeing people push their limits in various things, and even dealing with these minor injuries or
especially in hockey, right?
Yeah.
Like it's part of the reason they're there in the first place is they play an intense sport like that, and they have this level of grit that most people don't have, and that's exactly why they're able to play at that level in those conditions.
For sure. Those guys are tough.
Yeah,
I mean,
they are
some of the toughest athletes out there. I mean,
without a doubt,
they take a beating, and day in and day out, they're back out there doing what they need to do.
Mm-hmm. Yeah, for sure.
That lacrosse.
Gotta love that too. Let's put that out there.
Especially the goalies.
Especially the goalies. Yeah, the toughest of all.
So I think that's all we had on tonight's show list, if you will. Anything else?
No, man. Loved it.
Yeah.
Looking forward to next week and getting a bunch of shows out.
Oh, yeah. We're going to have
great stuff.
Yeah, so like we
NATA.
mentioned, we will be at NATA in Philadelphia next week, and I believe they're setting up what's called NATA Radio Row. We'll be set up there. You can check out our link in our bio and our Instagram page that takes you to our link tree with all the information. You can sign up to be a guest if you will, if you get there, and there's still some slots open. So before we go ahead and close out our tab tonight, we're just going to give a quick shout out to our sponsors, Virtual Orthopedics and Spine. From runner's knee to dog walker's hip, they have a doc for that. Yard work back and laptop wrist, they have a doc for that too. So Virtual Orthopedics and Spine has over 120 providers, over 20 PT and rehab facilities, and more than 25 surgical centers all across South Jersey. So find the right specialist for you at virtual.org/ortho. Protected 3D or Protected. Again, they're heading to NATA conference. We will be there. So if you're attending, go check out their 3D printed products in person. You can visit www.protect3d.io to learn more and where to find them at NATA. And like I mentioned, booth 1811, they will be there, Kevin as well. And then Neck of the Woods Brewing Company, serving of the best beer in South Jersey. We will certainly miss them at the convention. We won't be bringing beer to the convention.
Sadly.
Unfortunately. But we will have these great beer openers.
And then Timber Road Productions and our guy Kyle hooking us up and getting all this media out to all of our listeners. So thank you guys, and we'll see you next week.